Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is August 30th, 2025. This video is on a New England Journal of Medicine article published online today and also being discussed at the European Society of Cardiology meeting in Madrid this weekend, titled Beta Blockers After Myocardial Infarction Without Reduced Ejection Fraction. Beta blockers have long been standard for post-MI based on pre-reperfusion era trials. Unclear if beta blockers offer benefit post-MI in patients with preserved or mildly reduced left ventricular ejection fraction, LVF greater than 40% in the modern era. The REBOOT trial examined beta blocker utility given a contemporary revascularization and pharmacotherapies. The design was pragmatic, 109 centers in Spain and Italy. The study cohort comprised of 8,438 randomized, 4,207 received beta blockers, and non-beta blocker group was 4,231. Adults with type 1 or type 2 MI, left ventricular ejection fraction greater than 40%, post-invasive care. Individuals excluded were those with heart failure or with contraindications to beta blocker. Follow-up median 3.7 years. The primary outcome, it was a composite of all-cause mortality, reinfarction, or heart failure hospitalization. Stats, Cox regression, intention to treat per protocol analysis, sample powered at 85% to detect hazard ratio of 0.80. What did they find? Primary outcome, no difference. Beta blockers 22.5 per 1,000 patient years versus 21.7 in the no beta blocker group. P-value 0.63. All-cause death hazard ratio 1.06. Reinfarction hazard ratio 1.01. Heart failure hospitalization 0.89. No significant safety concern. Limitation of the study, open label design. The outcomes were centrally adjudicated. Lower than expected event rate, modest crossover, 12.9% beta blockers stopped, 17.6% no beta blockers started at 15 months. Dose and beta blocker agent not standardized, 85.9% were on bisoprolol. Key takeaways, beta blocker therapy did not reduce mortality, reinfarction, or heart failure hospitalization in post-MI patients with a left ventricular ejection fraction greater than 40%. Challenges existing guideline recommendations, Class 1 in the US, Class 2A in the EU. Possible signal for worse outcomes in women and STEMI patients. This is hypothesis generating only. Confirms findings of reduced AMI. Implications for future guideline revisions are significant. Notables. Stuart Pocock, PhD, co-author of REBOOT, known for the Pocock boundary in interim trial monitoring. Hay-Biddle-Peto boundary, classic method for interim analysis by John Hay-Biddle and Richard Peto. Valentin Fuster, senior author of REBOOT and editor-in-chief emeritus of JACC. Bora Ibanez, MD, PhD, PI of REBOOT, director of CNIC with a pivotal work in myocardial infarction pathophysiology. Henry Dargy, MD, lead of Capricorn trial, foundational for beta blockers in reduced left ventricular ejection fraction post-MI. Clinical pearls from this study, routine beta blocker therapy in post-MI patients with preserved ejection fraction may not be necessary. No reduction in mortality, reinfarction, or heart failure hospitalization in REBOOT trial. Pragmatic trial design with high real-world relevance, crossover, modest, and centrally monitored. Subgroup analysis suggests possible harm in women and STEMI patients. This is a hypothesis generating only. It reinforces findings from reduced AMI and Capricorn. Clinical practice guidelines may require updating. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.